I can hear you well. Yeah.
I wanted to say, I hope you remember your visit to our university a couple of years ago.
I do, yes.
And our brilliant students from that time have been eager to meet you again.
Good.
So right now we have, how many students do we have now? How many students are connected?
It's already...
So right now we have 234 students connected to our meeting, and they are still coming. So we are looking forward to hear a lecture today.
Good. Let me just close the blind. The sun is in my eyes. How do I do it? I'll be back in a moment, don't worry. Yeah. Right, okay. That's a bit better, the light. Yeah, okay. So, well, I'm ready to start when you are.
Yes, Dr. Marsh, after lecture, we will have many questions for you.
Okay, all right.
Is it okay?
Yeah, that's okay.
You'll be talking. Please go ahead.
So, Mr. Marsh, we are so glad that we can hear you now. And please, we are ready to hear some thoughts on such a difficult topic. So, Mr. Marsh, floor is yours.
All right. So I'd like to share the screen. Can you permit screen sharing, please? Can you share the screen? I have some slides. You need to enable screen sharing. All right. Yeah, there we are. Now let me bear with me just a moment. How do I get out of this? How do I minimize that? Escape. Yeah. Play from start. No. Sorry, this will take me a moment to get it going. There we are. Right, screen share. Share. Can you see the slides?
Yes.
You can, good, okay. So the plan was I'd talk about death and dying, which are difficult things to talk about. And certainly when I was a medical student and a young doctor, none of the senior doctors ever really discussed with me the problems we face as doctors with this subject. But of course, one of the special features, characteristics of being doctors is we have to deal with death and dying. Some of us very often, some of us only sometimes. But it is very much part of being a doctor. And it is very difficult, as I'll discuss. Now, as I said, for doctors, death and dying are really everyday events. When we are medical students, we dissect cadavers, dead bodies, and that really introduces us to a whole new way of looking at life. Whereas for people outside the medical profession, most people will only encounter death a few times, once for themselves, but only a few times usually for people they are close to. Although, of course, as we get older, we start to lose friends. And I recently have lost several friends from cancer. I don't think there's any doubt we all have a very deep fear of death and of dying. That is the famous painting by the Flemish 16th century artist Bruegel, The Triumph of Death, which embodies all our fears of death and the many ways in which we can die. And of course, disease and death is the one thing all of us as human beings and all of us as living creatures is one thing we all share and have in common. And as doctors, as I said before, we will often have to talk about it, but talk about it in different contexts, different situations. We may have to give a patient a deadly diagnosis, or a diagnosis where certainly there is a real possibility they will die from this disease. We may have to care for somebody who is dying, either when we are junior doctors working in hospitals, or if we go into palliative care and specialize in looking after dying people. And often we will have to comfort the family of somebody who has died. Each situation requires a different approach, but they're all difficult. It is always difficult. I think it is probably the most difficult thing we have to do as doctors. And many of us run away from it. And I certainly did quite often. We avoid, as we say in English, we avoid painful conversations. There are various reasons why we all fear death and dying. As I said, I think this is innate. This is hardwired into our brains. Just as we are hardwired to fall in love, we are hardwired to have children, most of us, and to love our children, most of us. But we are hardwired to be terrified of death. And there are various reasons we can rationalize this fear. There is the fear of pain and suffering. Now in countries like England, where we have on the whole a good palliative care hospice service, usually most death and dying is not too terrible. With opiate drugs, it's not particularly painful. But even with the best palliative care, dying can sometimes be very unpleasant because there are many, many different ways of dying, as you will learn when you are doctors. Perhaps you have already learned as medical students. If we are lucky, we drop dead from a heart attack or a stroke. If we are unlucky, we can have a disease like motor neurone disease or Parkinson's disease, or one of those terrible facial cancers that slowly destroys your face. So there are many, many ways of dying. Some are terrible, some are not. Some are very quick, some are very slow. Certainly in England and America, opinion polls, surveys have been carried out, mainly because of this question of whether to permit, whether to legalize voluntary suicide or doctor-assisted suicide. And one of the commonest, one of the most frequent anxieties people raise, and I would say this to myself as well, is we fear the loss of dignity and autonomy which dying involves. If we need nursing care, if we are paralyzed, if we're stuck in bed, if we're very weak, we are no longer free, independent people. And if we know there is no possibility, no prospect of our recovering, this is something all of us think is a horrible thought. Now, I assume almost all my audience are very young. All this is very remote from your own experience. And it is very difficult as healthy young people to put yourself in the mind of an older person like me. I'm almost 71 years old with a diagnosis of cancer although hopefully a cancer which I can live with for some years. But it's difficult when we're young, and I'd say the same for myself when I was young. I didn't really understand what my older patients were going through. And again, if you ask people, or if you read some of the books I'll mention, written by doctors who specialize in looking after patients who are dying, many people have regrets about the past, about broken marriages or mistakes they made. And to be able to die without regrets is very good. It's a privilege. And there's also the deep existential problem. This brings us back to the hardwired fear of death, of loss of a future. Because in many ways, what makes today good is the hope that tomorrow will be better. Or, in England now, we're all looking forward and hoping for the lockdown to come to an end, so I will be able to see my granddaughters in the flesh, for real, rather than just on FaceTime. And to lose a future, to know there is no future ahead, is very difficult. I can be a little bit philosophical about this, but I'll come back to religious faith in a moment. There is a very primitive animal called a sea squirt, which has a larval stage, if you remember your basic biology, and an adult stage. In the larval stage, here on the right, it has a notochord, a primitive nervous system, which in developmental biology, we can see where the notochord in so-called higher animals evolves into a brain. And it is said that the intervertebral discs in the human spine are derived from a sort of notochord, I believe. But in the adult, and the larval stage can swim, it can move around, which is why it needs a notochord and a primitive nervous system. In its adult stage, the larva turns into a series of tubes, forget the misprint, and it fastens to a rock and it no longer moves. And it doesn't have to move around to get food. It just sits there and food goes in seawater, these are seawater creatures, in and out of the tubes. And it reabsorbs its notochord. It throws away its brain. So there are deep evolutionary reasons for thinking brains developed, that is, if you accept Darwinian biology, which most of us do, I hope. There are deep evolutionary reasons for thinking that we develop brains to enable us to move, or us, all living creatures, to move. And to move efficiently, you need to predict what is going to happen. You need a model of the world in your brain. So when you're exploring the world, you already know to some extent what to expect. All of us have the experience if we go down a staircase and there is one more step or one less step than what we're expecting unconsciously. It's very confusing. For a few seconds, we feel completely sort of thrown out. So brains are really devices for living in the future in a model of what we expect. So in some ways, perhaps you could say, although this is a little fanciful and philosophical, our deep fear of death is because of this, we live for the future. And of course, death, unless you believe in heaven and hell, death is nothing. When we're dead, we've gone completely. Most neurosurgeons, we all have experience of seeing people who have suffered serious brain damage, particularly to the frontal lobes of the brain, where sort of social, moral behavior and also planning for the future does seem to be centered upon. And people with damage to those parts of the brain, they can, not always, but they can suffer very severe personality change. They don't know they've changed, but the family will say, he is no longer the man he was. He's been changed for the worse. he's lost all his interest and sympathy to other people. And when you see this, it is very hard not to think that everything we think and feel is produced by the physical substance of our brain. And therefore, when we die and the brain rots and degrades, that we have gone completely as well. Of course, if you believe in an afterlife, as some people do, some research has been done asking dying people with religion, you know, how they felt, and comparing that to dying people without religion. Most of the studies do not show much difference. And of course, if you believe in an afterlife, you might believe in hell down at the bottom of the Michelangelo Sistine Chapel. So in some ways, if you have deep religious faith, dying can be just as frightening as if you don't, because what happens after death? So these are complicated questions, but on the whole, the evidence is that religious faith doesn't change the suffering we all have when we are dying and know we are dying or are frightened of dying. Now, one of the many reasons why talking about death and dying is so difficult is that patients and their families will never tell us whether we have spoken well or badly to them. And it's very difficult to learn to do something well if you are never criticized. But one of the problems we have as doctors is that we are not criticized for the way we talk to patients. We'll be criticized for the way we operate, for the way we treat patients onwards by our colleagues and senior doctors, particularly when we're young and junior. But in terms of talking to patients, we get very little help, which does make it very hard to learn to do it well. And I, for one, I've no idea whether I did it well or not, because nobody has ever told me. I had to learn on my own, and I often learned from my own experiences. I was diagnosed with cancer after retirement, so I am now a patient witnessing the weaknesses and strengths of my colleagues. But I hope to pass some of my acquired wisdom on to you. So starting with the situation when you're talking to somebody, when you've made, either you or maybe your senior colleagues have made the diagnosis of a possibly fatal illness, such as cancer. First of all, you always must understand when you're having very serious conversations with patients, the patient will only take in, will only hear a very small part of what you're saying. This is not because they're stupid. This is because they're so emotionally, they're in such an emotional turmoil. They're in such a storm of fear and anxiety and denial that they find it very hard to concentrate on what you're saying. So you have to think very carefully how you're going to talk and how much you're going to say, particularly at the first meeting. And if the job has fallen upon you to break the news to the patient, you will certainly need more than one conversation. This I learned when I was a neurosurgeon in training at the famous Great Ormond Street Children's Hospital in London. This is many years ago, and the only brain scanner in London for children was at the hospital. So children who are suspected of having a brain tumor were sent to that hospital. And the diagnosis of the brain tumor was made in the hospital, and I was the senior junior, so to speak. And it was my duty to tell the parents that their child had a brain tumor. I was in the unusual situation of a few years earlier. My own son had had a brain tumor, so I had some idea of what the parents were going through. And what I learned very quickly was the news is so devastating when I'd have to tell the parents your child has a brain tumor. You couldn't say anything else. They were so shocked. You told them that, and then you had to wait and listen, as I'll discuss in a moment. But really then you need a second, much more detailed conversation, a day or two later perhaps, when you go over more of the details, what treatment will be required, what the chances of success are, things like that. But when you break the news the first time, it is like hitting somebody on the chin, and they really won't take very much more in. So it's a mistake to talk a lot, to try to impart a lot of information at the beginning. So you'll need more than one conversation, almost certainly. The other problem, of course, is, and I was like this when I first was diagnosed with my cancer, I asked the oncologist, how long have I got to live? Which is, of course, it's a very natural human question, but a pretty silly one, because the answer is no doctor knows. We never know how long an individual patient will live, not until really right towards the end. Because the simple reason is doctors, we deal with percentages. You could say, well, if I had 100 patients like you, I could say that 70 of you will be alive, or 70 of you will be dead in 5 years' time, and 30 of you will still be alive. But I don't know whether you're one of the unlucky 70% or one of the lucky 30%. And of course, this needs careful explanation to patients. Patients want to know what will happen to me, the patient, and how you express the fact that everything is uncertain. As I'll talk about in a moment, even with the most malignant brain tumors, a few people are alive after 5 years, although fewer than 5%. So the problem is you must never lie to patients. You must tell them the truth and what the figures are, but you must never take away hope. And that, of course, can be very difficult. The man on the left was a very, very good friend of mine and a world-famous potter. He has pots, ceramic vases in famous museums all over the world. And last year, he became a bit confused and having problems finding words. And his wife telephoned me and we arranged a brain scan. I mean, I helped arrange a brain scan because I'm no longer in practice as a surgeon in England. And his scan is there. It shows a typical fatal malignant brain tumor. It's a very typical appearance. And as soon as I saw the scan, I knew at once that he had less than 6 months to live. But because, of course, I specialized in dealing with tumors like this myself, and because he and his wife were very close personal friends, I felt obliged to help them. So I had to sit down and discuss the problem with him. And it was interesting having to do that really as a friend rather than simply as a professional. And there were two problems. I knew he was going to be dead within a matter of months. Though, as I said a moment ago, even with tumors, well, not really with tumors like this, but with malignant primary brain cancers as a whole, there are maybe 5% of people alive in 5 years' time. 60, 70% of people are dead within a matter of months, whatever the treatment. So how do you remain honest and tell the truth, but not completely deprive them of hope? Because if you deprive people of hope completely, they will waste what time they have left being utterly depressed. But if you're unrealistically optimistic and say, oh, you'll be okay, you'll be alive for years, that won't happen. And then they'll be angry with you for having lied to them, but also they'll be even more disappointed when they suddenly find actually it's much worse than you gave them to understand. So what I told him is what I told my own patients in these circumstances. Though whether it was the right policy or not, I don't know, because nobody ever told me. I'd say, look, this tumor will kill you. This is fatal, whatever the treatment. But if you are reasonably lucky, you'll be alive for a year or two, maybe longer, and we might be able to treat it again. And if you're very unlucky, you will probably be dead within a few months, which was in fact probably the more accurate prediction. So I told him that, and I think he and his wife, they coped very well with that, although I suspect the tumor was interfering with his understanding and emotional responses. He didn't really quite seem to respond to it, although he did understand quite clearly that he had a fatal illness. The other problem, which was more difficult in a way, was these tumors really are untreatable. It's conventional to do a biopsy operation and some orthodox conventional practice to give radiation treatment. Although if you talk to any neurosurgeon and say, does it make a difference? They'll all say no. But I couldn't bring myself to tell him that because I felt that somehow was depriving him of hope. So he had a biopsy which confirmed what we already knew. And he had a few weeks of radiation treatment, which was a considerable nuisance because radiotherapy hospital was a long way away from his home, and it did not help. And as I predicted, he was dead within 6 months. So he just became confused and sleepy, and actually he didn't suffer. So in that way, it was a good thing. But I was impressed by the way I couldn't bring myself to tell him that actually the treatment in his case really was just doctors trying to avoid a painful truth. And I continued that, and I couldn't bring myself to tell him that actually the treatment won't help. So it goes to show, even after years and years of dealing with problems like this, it does not really get any easier. If you look at the books about death and dying, there's a standard analysis that we go through stages of grief, both when we are told we are going to die or when we have lost somebody we love who has died. Often at first there is denial. We will not accept it, we cannot believe it. And then we can get very angry, angry with God, angry with fate, angry with the doctors and nurses treating us. And then we bargain and try to think that, well, if we do this or do that or find some extra special treatment on the internet, we'll live a little bit longer. And then we can become very depressed when we realize nothing can be done. And then perhaps with luck, we accept either the fact we're going to die or that we have lost somebody we love. Now, you don't want to get too rigid and fixed about these stages. Different people go through them to a different degree. But when you have to deal with patients or their families in these circumstances, it can be helpful to know that there are these stages we tend to go through. As I said, none of us know whether we have talked well to patients and their families in these circumstances or not, because we very rarely get to hear afterwards. But there are some simple rules, which really are the simple rules that apply to all of us if we want to be good doctors, as opposed to simply good technicians or good mechanics. The first rule is always sit down. You shouldn't have these terribly difficult, shocking, painful conversations of you standing up godlike and the poor patient lying down on a bed. But as you'll know if you've been in hospitals, this is the way things tend to be done. And of course, by having the doctor standing up, it puts the doctor in charge and control, and you can run away more quickly from what might be a painful conversation. You should never appear to be in a hurry. We often are busy and in a hurry. But what we want as patients is to be treated with respect and sympathy and patience. And somebody who appears very busy and talks very quickly and wants to hurry out clearly does not really care for us and is not interested in us. It's usually a good idea, particularly when having a conversation of this sort for the first time, to have somebody else in the room with you. I usually would have one of the nurses with me when I had to have conversations like this, or maybe one of my junior doctors. As doctors, we speak our own technical language, but when speaking to patients, most of whom will not be doctors themselves, you need to speak slowly with simple sentences, not as though you're talking to a child, but in a clear, simple way. And oddly enough, try to say as little as possible. Say what needs to be said, but you have to put yourself in the patient's position and think, what do they need to know? What will they be able to understand? Now, of course, this is where different educational levels, different cultures, I suspect in Ukraine, families are often more reluctant for patients to be told they have a deadly illness than, say, in England, where on the whole, families and patients say, I want to know the truth, however bad it is. And a very important principle when having serious conversations is to tolerate silence. Patients and their families will usually be so devastated and upset by what you're saying. They really have very little to say. But don't take this as a sign you can then leave the room because you've done your job. But it's very difficult to sit there in silence. I find I always tended to talk too much and felt I had to somehow fill the silent space between myself and the patients and the relatives by talking too much. And it took me many years to learn not to do that. And having said something which upset them a lot, to sit there quietly, waiting for them, maybe or maybe not, to respond, to ask a question, or to say nothing. As patients, and I found this myself as a patient, even though I'm a doctor, it's remarkably difficult often to ask doctors questions we're very hesitant to. Firstly, because we're frightened of hearing bad news, and secondly, because we're all rather frightened of doctors. Our lives depend upon them. We don't want to upset them. Doctors have great power. And when you are working in hospitals as young doctors, you'll probably see many doctors who have been corrupted by the power they have over patients, particularly perhaps in post-Soviet countries like Ukraine. And some patients and families are in denial. They will simply refuse to believe what you say. And it's no good arguing with that. Denial in some ways is quite helpful. You know, if you're dying, you'll be a lot more cheerful if somehow you manage to deny it or pretend you're not. So if patients are in denial, as we say in English, don't challenge it. You might try to gently question it, but don't say they're making a mistake. It's up to the patient. Patients have to do what's best for them, not what you think is best for them. And above all, listen to what patients and their families say. Watch them, observe them, learn from them, because as young, healthy people, the only way you're going to understand what it is like to be in my situation at the age of 70 with advanced treatable cancer, you will only learn what it feels like by listening to patients tell you what it's like. And even then, it's still very hard to imagine, to get your head around it. But good doctors listen. And listening is a very important part of communication, but it takes time, of course, and that's difficult. We often don't have the time. And even when we do have the time, we don't always want the time because we find these conversations difficult and frightening. And you should read books. I don't know what the Ukrainian medical literature is like on this painful subject. The classic work was written by an Austrian-American doctor many years ago now called Elizabeth Kubler-Ross, who started the whole scientific study of treating dying patients and writing about it. And it's a good basic book. And then the more recent books like the one on the right, written by a friend of mine who is a palliative care doctor in England. She specializes in looking after people who are dying. And it's a very well-written book. I think there hopefully will be a Ukrainian translation available at some point in the future. So by reading books, it can help broaden your understanding of what your patients are going through. So that is my talk. I'll cancel screen sharing now, and I'm happy to answer any questions. I have about half an hour for answering questions before I must go.
Thank you, Mr. Marsh, for such a thoughtful lecture. And let us actually proceed to questions from our audience. So, do you hear me well?
I can hear you, yes.
Okay, so first question is from Yulia Ticholas, and she asks, is it possible to teach medical students to be empathetic, or is it a knowledge that cannot be taught in university? What do you think about it?
Well, we need to talk a little bit about what the word empathy means. The strict meaning of the word empathy in English means to actually feel yourself what somebody else is feeling. Now, obviously, if every time you put a needle into a patient, if you felt their pain, you couldn't do the work. So we have, in many ways, we have to learn to suppress our empathy and not feel our patient's pain. But then we have the English word sympathy and also compassion. Sympathy means to feel sorry for somebody. Compassion means to feel sorry for them, but also to care for them at the same time. I think these are difficult things to teach in the way you teach anatomy and physiology and pathology. But all of us as human beings, we are very influenced by the people around us to a greater or lesser extent. It is said that 5% of the human population are psychopaths in the strict sense of the word. They simply lack human empathy. They just don't feel other people's feelings. Doesn't mean to say that they can understand other people's feelings, which is why some psychopaths are very good at manipulating people, but they don't feel any instinctive empathy. And all of us vary when we go to medical school or work in hospitals in our personalities. There's the balance between how much we care for patients and how much we don't. But most of us, apart from psychopaths, are very influenced by the people around us. I don't think you can teach empathy by telling people, you should be sympathetic, you should be empathic. But I think by seeing good doctors at work who listen to patients, who care for patients, and as medical students, you're in a good position to talk to patients because patients are not frightened of you in the way they're frightened of doctors. So I think you can learn sympathy and compassion. Some of it's innate. I might be wrong, but I suspect women are naturally a bit more compassionate than men. Men, we're more concerned about showing off and ambition and ego, but these are complicated variable things. So yes, you can learn empathy. Whether you can teach it as such is more difficult, but you certainly can, as a senior doctor, you can set a good example. And I suppose my lecture today and the one or two stories I've told were a way of trying to help you learn empathy. It's all about what we call in English the golden rule. Do as you would be done by. Treat patients as you would wish to be treated yourself or members of your family to be treated. That is a policy of perfection and often very difficult, if not impossible. But you need to go into your medical careers always remembering that that is the ideal target of everything you do. That would you want to be treated like this yourself? It's a policy of perfection. We often have to compromise and don't do it, but when we compromise and fail, we should try to admit that rather than pretend we haven't failed.
Thank you. And the next question is actually a follow-up to the first. What do you think about bioethics courses in medical universities? Should they be taught?
I have no experience of them. I mean, to me, I'm rather skeptical about bioethics. It's a branch of philosophy. I'm a practical person. So the answer is I don't know, because I've not seen what they're like, but I'd be rather skeptical. I think you learn more about medical ethics by seeing doctors at work than by hearing theoretical doctors philosophizing about it. But there'll always be exceptions, you know. And you'll learn from seeing bad doctors handling patients badly. You'll learn as much from them as you'll learn from good doctors. And I'm sure there are some good bioethical lecturers who are very good at it. But to me, empathy and compassion are essentially practical crafts. You learn by doing, you learn by watching. You don't learn by studying in an academic, theoretical way.
Thank you. And actually, a lot of people asked in our Google Forms about what do you think about euthanasia? Is it a way or it is?
Well, I feel very strongly it is a good thing. It is available in many countries. So, I mean, Australia, many American states, Canada, New Zealand, Holland, Belgium, Switzerland, Japan. So there is plenty of evidence to see whether it works well or not. And I think we can say fairly clearly, because in all these countries, they've analyzed the practice of assisted suicide quite carefully. And there are different ways of doing it. And it seems it is not being abused. It is not leading to greedy relatives killing their parents to get the family silver, which is one of the common arguments against it. Faced by death from cancer myself, hopefully not for some years, I'm angry that in England we do not have assisted dying. I would like, if I knew we did, I would not have to worry or feel frightened about the fact I might have quite a distressing, unpleasant death. And one of the strong arguments for assisted dying is that when you are dying, you don't have to worry about that if the end becomes very unpleasant, it needn't be. We know from research in Oregon, the state in America, where they've had assisted dying for 20 or 30 years now, that many people, when they go into hospice care and palliative care, when they're no longer trying to be kept alive, but just the purpose of treatment is to keep them comfortable. Many people are expressing interest in assisted dying, but when actually the end comes, they don't take it up for a variety of reasons. But the reassurance that it is possible, I think, is very valuable and very important to reduce anxiety and suffering at the beginning of your final illness. The arguments against it, although nobody can say it's religion, they have to come up with other arguments. They say that people aren't rational when they're dying, that it'll be exploited, that none of them are very convincing arguments. And as I said, looking at countries where assisted dying is possible, does not bear it out. This does not seem to be a problem. Most people, when they're dying, do not opt for it. And there's also the other final argument, as I mentioned earlier. Even with very good palliative care, some death can be very unpleasant. If you're dying from a facial tumor, if you're suffocating from a tumor of the throat, something like that. And the opponents, the people who are opposed to legalizing assisted dying, essentially they are lying when they say that all death need never be difficult. With good palliative care, it's always going to be easy and comfortable. It simply isn't true. It's true most of the time if you have good palliative care and if you have a good supply of opiate drugs. But in many countries in the world, opiate drugs are not easily available. And one of their biggest uses is for treating people who are dying. On that note, I might just add some very interesting work in recent years on using psychedelic drugs like LSD or psilocybin, magic mushrooms, for psychotherapy for people who are dying. And it can be enormously effective. A single dose, a single good trip, well managed, apparently has an almost miraculous effect on people who are depressed and anxious. about dying. Very interesting work.
Thank you. And we have a question from our live. Kainat Havaya, I suppose I pronounced it well. Doctor, you mentioned how we as doctors shouldn't have opinions on what's best for the patient. But what if the patient is making a decision based on poor medical knowledge?
Well, ultimately, all you can do is try to explain to them the knowledge is bad. But as I said, if a patient is in denial, you can't argue with it. Occasionally, I had patients who refused my recommendations, in which case I said, well, you'll have to go and see another doctor then, but I can't go on treating you. You know, you don't, if a patient disagrees with you, you don't have to insist. You can tell the patient politely, well, you'd better find another doctor, but we are not going to agree.
Thank you.
It's a challenge of your communication skills. If you know that they've got bad medical knowledge, and some of the medical information on the internet is not good, well, it's a challenge for you to try to explain to people why they might be wrong. But if you fail, well, you have to accept that.
Right, thank you. And another one is from Anna Maria Shulhai and a lot of our students. Is it possible to deal with the death of the patient absolutely, even if there is no your guilt? What is the correct way of psychological recovery? What may be your tips, especially for young physicians?
Well, recovery of the doctor.
Yeah, right.
Yeah. Well, first of all, if you aren't upset when a patient dies, you're not a good doctor. It is a sign of being a good doctor that you are distressed by death. But we all have to die sooner or later. And when our patients die, this does not necessarily mean to say we have failed. And we've only failed if their death could have been avoided with different treatment. If that was the case, we should feel terrible, but we have to learn from the mistake. If they died despite having the right best treatment, we should feel sad they've died, but that is life. All of us die sooner or later, and young people sometimes die as well. Children sometimes die. And then the challenge is that the dying was as dignified as possible, and we've looked after the family as well as possible. But I know that with the pandemic, my colleagues, we often make difficult decisions who to treat, who not to treat. But there have been so many deaths from coronavirus. That is very difficult. It's very stressful. Whether the doctors and nurses working on intensive care units will develop post-traumatic stress syndrome or not, as some people say might happen, I do not know. Post-traumatic stress syndrome is a complicated problem. What we do know from research into soldiers with post-traumatic stress disorder is that one of the factors that makes you less likely to have it is good leadership and good colleagues, good teamwork. So if you are very upset about the death of a patient, talking to colleagues who understand, other doctors, non-doctors don't understand, but having colleagues who trust and can talk to is very good therapy. And good leadership above all. If you have good senior doctors who will help you, that is very, very important. Having said that, all of us have a different threshold for getting upset and stressed. And if you have very, very, very many deaths, everybody will get stressed eventually. It varies from person to person. But good leadership, good, kind, supportive leadership, and good colleagues are very important. You shouldn't, if you feel very bad about a patient's death, you shouldn't bottle it up inside yourself. You should talk about it but ideally two colleagues who will understand. Just talking in itself helps. Excuse me just one moment. Hello. No, it's not. It's number 5 probably. Okay, bye. Right, sorry. Yeah, I'm back.
I wish that this answer will help some of our young physicians. And another one from Oksana Puri and Olena Korotun, they are young pediatricians, and you have touched that topic in your lecture, but you had a really hard pediatric cases in Ukraine in your practice. And what will be your first, maybe, how to not break the parents when they just hear that announcement that their child has a fatal diagnosis?
Well, again, there are no simple answers to this, and I never knew whether I did it well or did it badly. It really, I would refer you back to my slide about not being in a hurry, talking simply, tolerating silence, accepting the parents will break down into tears, not to feel threatened by the fact they will say, well, could somebody else do more? And that is, of course, one of the problems in Ukraine. The parents will all say, well, if we went to Germany or America, if we had $100,000, would the treatment be different? And of course, sometimes it's true, the treatment might be different. But I mean, compared to when I started working in Ukraine 30 years ago, although the situation in Ukraine remains very difficult, on the whole, the gap, the difference between Western medicine and Ukrainian medicine is a lot less now. And on the whole, when I've been in Ukraine in recent years and seen children where the parents have been told there is no treatment possible in Ukraine, I've usually been able to say, well, the situation is no different in America or Europe. But there is this problem of credibility, and Ukrainian patients and their families don't necessarily trust their doctors to the extent we do in England. And that's if that's the case, that's difficult. All you can do is listen to their questions and try to answer them as honestly as possible. And if you think, well, maybe another hospital somewhere could do better, well, fair enough. But that, coming back to the earlier question, I've often seen cases in Ukraine where the wrong treatment has been recommended, usually for money, by another surgeon. And then that's very difficult because desperate parents will do anything and are easily exploited by doctors who perhaps should know better. But at the end of the day, if the parents insist on spending $10,000 on an operation I think is a mistake, well, it's their choice. All I can do is try to explain as clearly as possible what I think is the truth. But these are really, really difficult problems. I think that dealing with desperate, anxious parents is one of the most painful aspects of being a doctor, particularly a pediatrician. But we have to do it. It's that's the nature of the work. That's what makes it difficult, is also what makes it special.
Thank you. And the next one is from our graduate, Yulia Tesluk. She's now a young nurse in Canada. And how nurses and doctors should interact regarding palliative patients, how that interaction can influence the patient, and what not to do in that interaction to make things worse for a patient.
Well, I've not worked in palliative care, so I don't have that much personal experience. But in general terms, the better the working relationship between doctors and nurses, the better the care patients will receive. It's certainly very important that the patient and the family hear the same truth from all the clinical staff at different levels. So you don't have the nurses saying one thing and the doctors saying something else. So it's very important that doctors and nurses communicate well among themselves so they all know what the patient's being told and they all agree. So I think all palliative care departments have regular meetings where all the staff and therapists are present and they work together as a team. And the doctors are responsible for the diagnosing and the drug treatment, but really much of the rest of the care is done by the nurses. As doctors, we spend only a few minutes a day with patients. The nurses will spend hours and understand and know the patient's needs much better than we do as doctors. It's teamwork, 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 teamwork.
That's a nice answer. And somewhat more distant question about, you have mentioned it as well, you touched it in your presentation, and over the years you have gained a lot of knowledge about the activities of the human brain. Has this knowledge become a burden for you? How does it feel to meet aging with that knowledge?
I'm writing the third book, and the third book starts when I had an MRI brain scan, really as part of research to help a colleague. And it shows quite a lot of atrophy and age-related changes, the equivalent of gray hair and bald head. And it was pretty frightening, is the answer. But at the end of the day, knowing that our brains deteriorate, as for most of us, as we get older, is actually no different from knowing that we're all going to die. Old age is a problem. It's the problem of the corona pandemic. 80% of the deaths are in people over the age of 80. We are sacrificing, maybe destroying the futures of your generation and your economic prospects, mainly for keeping a large number of old people alive for a few more years. I don't know what the answer to this is. I can't imagine any politician standing up and say, let the old people die. But certainly the problem in England with the pandemic has been the hospitals have been filling up, not with old people, but with people in their 50s and 60s, almost all of whom are obese or overweight, have previous health issues. They're the ones who die who could be saved by hospital treatment. But politically, the effect of the coronavirus pandemic is expressed in terms of tens of thousands, hundreds of thousands of deaths. And those are mainly old people in care homes. And in English, we used to say pneumonia was the old man's friend. That as we grew old, we'd all eventually get pneumonia and die. This is before antibiotics. If we live to the age of 80, we have a 45% probability of getting Alzheimer's disease. There is a steadily progressive epidemic of dementia in the developed world because more and more people are living longer and are costing more and more money. So old age is a problem. I try to keep it at bay. I run a lot, I exercise every day. But I have mixed feelings about my cancer. Sometimes I think, well, if I die from cancer, maybe that's better than living another 10 years and dying from dementia. Who knows? I don't know. But it's difficult. We do know that as you get older, you enjoy a better quality of life if you exercise and have exercised regularly. But we also know that people higher up the social ladder enjoy better health and live longer than people at the bottom of the social ladder. And that's not just about access to healthcare. Just knowing you're at the bottom of society makes you more vulnerable and shortens your life.
That's a great answer. And I wanted to ask, and a lot of our viewers are asking about inspiration. And how do you get your inspiration for books in environment of, it is not usually, but it is occasionally a death in your practice as it was?
Why do I write? Well, I've written all my life. I started writing when I was very young. I never planned on writing books about my work as a doctor, but I wrote every day a diary, and then various people, mainly my wife, said, well, that could be a book. You write very well. And eventually, that's why I wrote my books. I enjoy writing. As doctors, we live very interesting lives. I think we live inspiring lives. What could be more inspiring than trying to help our patients, even though it can come at a terrible price, and in a country like Ukraine can be terribly, terribly frustrating, because the healthcare system in Ukraine, like so much of life in Ukraine, is chaotic and corrupt, and there's no prospect of that changing quickly in the near future. But I think I've always loved, I went into medicine late in life. I did not become a doctor until I was almost 30 years old. I've often found it very difficult and very painful, but I always loved the work. I don't miss it. I'm happy to have stopped operating now. It is better to leave too early rather than too late. But I find medicine interesting. It's people. I've always been fascinated by people. And I love people on the whole. It's why I've tried to travel all over the world, not to see famous places, but to meet people from different cultures. And I think if as doctors we're motivated by finding our fellow human beings interesting and fascinating and sympathetic, we will be good doctors, whichever of the many different types of medicine you go into.
Thank you. And the last question, what we have is maybe more positive. So what will be your wish to Ukrainian medical students and community overall in these unstable times of pandemic?
Well, with the pandemic, I don't know. I'm not sure what's happening in Ukraine with the pandemic. What you need in Ukraine is good postgraduate education. You need a proper, structured postgraduate educational system for when you have qualified as doctors. The old Soviet system is terrible. So you get your license as a specialist after 3 years of lectures. This is a huge contrast to Europe and America. Whether that will come or not in Ukraine, I don't know. As far as I can see, undergraduate education is good enough. But the problems, to me, seem to start afterwards. That's what I would hope for you all, that you will have better postgraduate training, not just the professor's son system of postgraduate training.
Thank you. And that answer concludes today's meeting. And I want to give a word for our rector. So please.
Dr. Marsh, thank you very much for this very interesting lecture. About 300 students have been watching you and listening to you, and your knowledge, your experience, your thoughts are priceless for us, are very valuable for our students. And I really hope that this lecture and your books will help them in their future profession. Dr. Marsh, we would like to invite you to our university again, and we hope very soon to meet you face to face, but not virtually like today, you're very welcome to visit us. Thank you
very much. Well, let us hope one day the pandemic and the lockdown comes to an end.
Hopefully very soon.
Hopefully. I long to return to Ukraine.
Thanks a lot.
All right. Okay, everybody.
Bye-bye.
Right. До побачення. Bye-bye.
До побачення, Mr. Marsh. And I want to... Хочу подякувати всім, хто нас слухав, усій нашій аудиторії, також адміністрації університету, яка допомогла в організації даного заходу. Також він відбувається за ініціативою студпарламенту Тернопільського національного медичного університету. І ми справді сподіваємось, як сказав Михайло Михайлович, зустрітися наступного разу з містером Маршем уживу. Дякую всім за увагу, гарного вечора, гарного дня.